Okay, so this lecture is going to look at some of the treatment options that exist for panic disorder, learning objectives. I wanted to do a quick physiology, pathophysiology mini review. There's no learning objectives here. You're not going to be tested on this, at least by me, but you will be tested on this, I'm sure, by neurology, neuroscience, and psych. But in terms of depression and some of these other centrally acting diseases, there's several theories that exist, one of which is the catecholamine theory. And I just wanted to draw your attention that when we talk about catecholamines, we're really talking about the process of converting tyrosine into these derivatives, particularly dopamine and norepinephrine. And basically, to remind you that these catecholamines have structural similarity in terms of their chemistry. And so also you can see some binding across the different receptors. And so it always bothers students initially that, some drugs that bind to dopamine receptors can also bind to norepinephrine receptors and so forth. And this is because there's a high degree of structural similarity. So when we talk about catecholamines in general, we're really referring to dopamine, norepinephrine, and of course epinephrine. And of course the source of norepinephrine in a lot of these diseases is the locus coeruleus. And excuse me, this portion of the brain is critical for arousal and wakefulness. And so you can see where, decision making, learning, memory, motivation, anxiety, attention, and some of these other things that, at normal levels are part of our everyday function, but in disease levels can be problematic. And this is where many of these drugs are going to have their effects. Likewise, when we talk about serotonin, I want you to understand that serotonin is derived from tryptophan and is structurally different from the catecholamines. This technically is an indolamine, but you can see there's some common enzyme binding partners that exist. And so when we talk about catecholamines and their affinity to different receptors, there's a much stronger crossover between dopamine, norepinephrine, and epinephrine than there is serotonin. But there is still some crossover between serotonin and catecholamines. And so, yeah, from a chemistry standpoint, yeah, these are different molecules, but indolamine versus catecholamine are slightly, there's some common structural similarities, basically amines. And you'll see that recapitulated when we talk about some of the other drugs in this category. And I do want to remind you that, of course, the source of a lot of the serotonin is the raphe nucleus, and a lot of these projections have wide-reaching projections to almost every region of the brain. And of course, from a receptor standpoint, there's upwards of 14 or 16 different serotonin receptors, the majority of which are G protein coupled receptors and signal very similarly to the adrenergic receptors that we learned about when they bind to catecholamines. There's two serotonin receptors that are ligand-gated ion channels, and so of course they behave slightly differently. One thing that I wanted to point out too, that the previous lecture was about depression and bipolar disorder, and one of the things I forgot to mention is that, what are the other causes of depression? And so, we talk about it from a pathophysiological standpoint, but also from an iatrogenic standpoint. So this is a great summary table, and it kind of puts everything into perspective. I do want to point out that a lot of these pharmacology lectures, there's going to be a lot of overlap. We're going to talk about SSRIs probably in every lecture. We're going to talk about benzodiazepines 3 or 4 more times. And so there's going to be spaced repetition of all these drugs. Hopefully, as we go through this, you'll kind of be able to put them into clinical baskets as to where these drugs have the most efficacy. This is a great summary diagram that you can keep and you can study. There's several medications that may actually lead to depressive symptoms, shown here in Table 2 on the left. And there's also medical conditions that may lead to depressive symptoms. And I think Dr. Dance had talked about this in one of his lectures, that patients that have, these kind of long-term debilitating diseases that basically interfere with daily life can exhibit depressive symptoms. And so so some of these things are comorbid, and some of these things happen about because of the patient's history. I included this picture because I liked it. There we go. I do wanted to revisit efficacy delay, and I think from a conceptual standpoint, I think most of you are pretty familiar with this concept and are able to define it. But what I really wanted to do is kind of go into a little bit more detail. And so we know that when you first prescribe one of these antidepressant medications, there's a delay in which the patient feels better. We can characterize this by an improved mood. The reasoning behind it, we said it was basically at the protein level. And the next slide really kind of nicely summarizes this. And so this is what this looks like. And so this is the concept of counteradaptation. And it's a little bit more complicated than this, but I kind of like this diagram because it basically summarizes what's happening. And so this is basically looking at within the locus coeruleus, some of the pathology that exists there. And here's looking at the raphe nucleus. And so in depressed patients, you can see an increased neuronal firing rate and the corresponding effects of postsynaptic alpha and beta receptors. And so as the rate changes, and it does change when we start adding on drugs, there's compensatory mechanisms that come into play. And so you can see the alpha receptors have a reduced effect because of all this norepinephrine release, and there's a corresponding change postsynaptically. And so when we had talked about that negative feedback loop that exists at the presynaptic level, there's also a feedback loop at the postsynaptic level. And so basically what happens is that anytime you change the number of these receptors, either postsynaptically or presynaptically, you're going to affect physiology. And so this is looking at norepinephrine and alpha and beta receptors. The same could be said looking at serotonin receptors as well. A little bit more complicated because some of the serotonin receptors are stimulatory, others are inhibitory, and we're not going to go into more detail than that. But this concept of counteradaptation really explains kind of the mechanism and the underlying biology in terms of when you add a centrally acting drug, there is going to be physiologic brain changes both at the receptor level, which is shown here, but also at the protein level. And so Dr. Danza talked about certain brain-derived growth factors and some of these other proteins that are involved with basically maintaining homeostasis. Those are all affected differently by a lot of these centrally acting drugs. And so this notion that efficacy delay exists and it can be explained by counter-adaptation mechanisms, which we don't need to go into great detail here, really kind of tell us that whenever there's a centrally acting drug, we have to be mindful that there's corresponding physiologic changes, and these changes take quite some time. So this leads us to this really well-known axiom that says, it's shown there at the bottom, never abruptly withdraw a centrally acting drug. Okay, and you really have to kind of remember this and for clinical practice, is that if a patient's been on any of these antipsychotic, antidepressant type medications, these are all centrally acting, they're quite potent, you can't just have them stop cold turkey. They will have withdrawal symptoms. These counter-adaptation mechanisms will really kind of produce those withdrawal symptoms. The body will not be happy, the patient will not be happy, and they will have an unpleasant side effect withdrawal profile. Okay, so this just kind of gets at some of the biology about this, and so I just kind of wanted to put this a little bit forward.